Okay, CVS, cardiovascular system. We know the heart is in the mediastinum, behind the sternum, dislocated between the second to the sixth rib. You can see that the base of the apex of the heart is in the fifth intercostal space. So the first one is here first, second, third, fourth, and then the fifth intercostal space. It's also located between thoracic uh, vertebrae 5 to thoracic vertebrae 8. And then the coverings of the heart. The heart is going to have first a pericardium. Now the pericardium is going to be divided into fibrous pericardium and serous pericardium. The one which is fibrous is the outermost layer, and then the serous is the inner layer. Now the serous pericardium can either be parietal or visceral, meaning that there is that part that is connected to the heart itself, and then the other part is not connected to the heart. Okay. And then between the layers, you also have the pericardial sac. So that is between the parietal layer and the visceral layer. So you can see here is the pericardium having the fibrous layer and the serous layer. The serous layer is the one that you are able to see here, and is going to also have two layers. You can also see, okay, starting with fibrous niche, this one which is outside the fiber, and then the serous, think of it like you've made a balloon and then you put your hand in. There is that part of the balloon that is going to be near your hand, touching your hand, that is a visceral layer. And then you also have the parietal layer. The visceral layer, just know it's also known as the epicardium. The space between these two, that is the pericardial sac. Okay. Okay. And then we also need to understand the walls of the heart. So as we've said, we have got that layer that is from the serous pericardium, which is the epicardium, and then we also have the myocardium, and then the inner layer that surrounds the heart is the endocardium. The myocardium, this is the muscle layer which will make up the having the the cardiac muscles, which forms the syncytium. Okay. And then, so this is just it showing the layers. Pericardium, myocardium, you can see very thick, and then the endocardium. Chambers of the heart, the chambers, we have got those, the arteries and the ventricles. The arteries are there to receive blood and they are on top. The ventricles, they'll pump blood. Now if you compare the two ventricles, the left ventricle is much thicker than the right ventricle. That is because the left one is going to be pumping blood for a longer distance. Okay. And then dividing these ventricles and the arteries, we have got septors. So I've got the interarterial septa, the interventricular septa, and the atrioventricular septa. So the atrioventricular septa is dividing the atrium from the ventricles, and then the interventricular between the two ventricles. Now, if you look at these septors on the surface, if you look at the heart, they are going to produce some external grooves. So it seems as though the heart is going inside where you have got the septors, and we call them the sulci or sulcus. So for example, you have got this sulcus here between the left and the right ventricles. So this is the anterior interventricular sulcus because it's in front. And then you also have this one between the ventricle and the atria. So that is the atrioventricular sulcus. The apex of the heart is found on the bottom here, while the base is located on the posterior end there. And the apex of the heart is inferolateral, it's laterally, found in the fifth intercostal space. It's 9 centimeters from the median plane. So if you come on the midline of the body, 9 centimeters from the midline in the fifth intercostal space, that is where we find the apex. And if you want to listen to the mitral valve, you actually use the where the apex is. The base of the heart is located posteriorly, and it is mostly formed by the left atrium. This is what you can see. Okay, the base of the heart. And this base of the heart is located between T6 and T9. And then on top, it will extend to where the pulmonary trunks are going to be able to bifurcate. You can see this is where the pulmonary trunks are able to bifurcate. And the major part is the left atrium, the major part of the base. Inferior to where there is a bifurcation of this trunk, you have got the coronary sinus, which is going to receive blood from coronary veins. The heart has got also different surfaces. You have got the anterior surface, which is also known as the sternocostal surface, because it is in relation to the ribs and the sternum. It is mostly formed by the right ventricle. The diaphragmatic surface, which is also inferior, this one is formed mainly by the left ventricle because it's the one which lies on the diaphragm, and also a bit by the right ventricle. The right pulmonary surface is formed mainly by the right atrium. This one is related to the lungs. Okay, in this case, it's the right lung. And then the left pulmonary surface, this one is going to be formed mainly by the left ventricle and is going to form the cardiac impression in the left lung. Okay, so this is how it looks. You can see the left pulmonary this side, the right pulmonary, the base posteriorly there, and then the anterior side here, the diaphragmatic surface down, and also the apex. We have got the coronary sulcus. Coronary sulcus, remember a sulcus is just like a depression, a groove. So this one is going to separate the atrium from the ventricles. That's the coronary sulcus. And the coronary sulcus is going to contain the right coronary artery, the small cardiac vein. The biggest of them is the coronary sinus, which is this one here, and then the circumference branch of the left coronary artery. We are going to talk about each one of these. We also have the interventricular sulcus. Now, the interventricular sulcus is a space between the two ventricles. So we're going to have one which is posterior and one which is anterior. The anterior interventricular sulcus is going to have the anterior interventricular artery and the great cardiac vein, while the posterior one is going to have the posterior interventricular artery and the middle cardiac vein. And then for the atrium, it receives deoxygenated blood. Okay, and then we know that inside, this is basically the right atrium we are talking about. Inside we are going to have the tricuspid valve, the right atrioventricular orifice, and all those. Inside also are going to have some kind of roughenings of the muscles. Okay, so we're going to have also the crista terminalis and also some muscular ridges. So where the smooth part and the rough part of the right atrium are ending or dividing, you have got the crista terminalis. Posterior to the right atrium on the smooth surface, you are going to have the sinus or the vena cava. You are also going to have a point where the coronary sinus is going to take its blood. Also the superior vena cava and the inferior vena cava. So this is the one. You can see you also have the fossa ovalis, which is the remnant of what was this, also foramen ovale. Okay, that's the fossa ovale. The anterior surface is rough while the posterior surface is smooth. It has got the anterior surface, the anterior wall of this right atrium has got some roughenings which we call muscular pectinate. Posteriorly, we are going to have an opening for the coronary sinus. Okay. And then for the right ventricle, it has got also some muscular ridges which we call as trabecular carne. There are also some papillary muscles attaching to the surface of the ventricles. And the other end will be able to attach to the tendon cords, which we call cordate tendinae. Cordate tendinae, these are fibrous cords which connect the free edge of the cups of the tricuspid valve. So this is what we can see here. You can see this is a valve, and in this case it's a tricuspid valve found between the right atrium and the right ventricle. You have got the raisings, these guys. You have got first the trabecular carne, which is the surface, and then you have got these cusps which we are holding by chordae tendinae. So we have got chordae tendinae holding into the papillary muscles. Papillary muscles, we have got the anterior papillary muscle, we have got also the posterior papillary muscle, and also the septal, because they're on the septum. The tricuspid valve, as you already know, is found between the right and left atrium. It is tri because it has got three cusps. And then for the left atrium, we know that it is going to be able to take blood that is coming from the lungs. It's going to be able to receive 4 pulmonary veins also. Okay. It also has got some roughenings, muscular ridges, which we call the musculi pectinate. And for it has got the valve of the foramen ovale. Valve of the foramen ovale, not the foramen ovale itself, because the foramen ovale is on the right atrium, but the valve is found on the left. You can see this is the valve of the foramen ovale. If you go to the right, you are going to see the foramen ovale. The left ventricle and the left atrium will be separated by the mitral valve or the bicuspid valve. Okay. And then for the left ventricle, it also has got trabecular carne as the roughenings, or as the part of the muscles which are forming the rough surface. So you can see the trabecular carne is still there. But then, because it has got a bicuspid valve, it only has two cusps connected to the anterior papillary muscles and the posterior papillary muscle. There are no septal papillary muscles here. So these are again that you are able to see in case they bring in this way. Pulmonary valve on top, aortic valve, mitral valve looks to be on the left, and then tricuspid looks to be on the right. For the arteries, blood vessels. Blood vessels have a thick muscle layer. They are going to be divided into arteries, veins, and capillaries. Arteries carry mostly oxygenated blood, except for those which are pulmonary arteries, which go to the lungs. Now, these have thick muscle layers in proportion to the diameter. You can see very thick muscle but small diameter, opposite to the veins, which have got a big diameter but small muscle layer. And then you also have capillaries, which are going to be able to connect the veins and the arteries, actually venules and arterioles. For the capillaries, we have got different types of capillaries. Continuous capillaries. Continuous capillaries do not break. They do not have any openings in them, meaning that when blood is moving out of through the continuous capillaries, it cannot be allowed to go out. Okay, so it includes those arteries found in the muscles, in the skin, in the lungs, and also in the central nervous system, forming the blood-brain barrier. You also have fenestrated capillaries. Now, these ones are specifically found where you are going to have increased permeability so that there can be exchange of large molecules like proteins and hormones and nutrients. For example, in the kidney, in the endocrine glands, and also in the intestines. Sinusoid capillaries are, are located more where you want to let large molecules, blood cells, and immune cells to be able to pass. So mostly going to be found where there is immunity being involved, like in the liver, bone marrow, in the spleen. So this is going to be sinusoid capillaries. Now the arterial supply to the heart. The heart is mostly is supplied by coronary arteries. The right coronary artery and the left coronary artery. The right coronary artery is going to originate from the right aortic sinus. It's coming from the ascending aorta. When the ascending aorta comes from the heart, it will now give the right coronary artery from what is known as the right aortic sinus. And then this right coronary artery will be able to go to be able to ascend, okay? I mean to pass anteriorly to the right and then go to the right auricle. But what is important is that when the right coronary artery is moving, it will give these many branches. SA nodal branch, the blood supply to the SA node, which is the pacemaker of the heart, the right marginal and the posterior interventricular branch. While the left coronary artery also comes from the ascending aorta, from the left aortic sinus, it will give the main branches being the left anterior interventricular. The left anterior interventricular also gives off diagonal branches, and the circumflex branch, which gives the left marginal branch. So this is what we're talking about. You can see the right coronary here. It will give, I mean the left, this is the left. It will give the anterior interventricular branch or artery. And this one will also be giving diagonal arteries. And then there's also the circumflex branch. The circumflex branch will be the one which will go to the posterior, okay? And then to also give the left marginal, so there'll be an artery which will be moving along the margin. That's a left marginal branch, and that's the one that you can see named there. And then for the right one, it is giving a branch that is going to the SA node, that is the sinoatrial nodal branch. It's also giving a branch going down, okay, and then also this same branch will turn downward there. It turns and then goes only the posterior interventricular sulcus as the posterior interventricular branch of the right coronary artery. It also gives the right margin of this artery which is going along the margin. That's the right marginal artery. So these are the branches simplified. You can see from the right coronary artery is giving the SA node of artery. So the many arterial supply to the SA node comes from the right coronary artery. You can see the left coronary artery also will give us a branch that will go to the SA node, which is coming from the circumflex artery. Okay. And then the venous drainage. Most of the veins of the heart will go first to the coronary sinus. This is the one which you can see posted here. And this one will be able to drain into the right atrium. The coronary sinus will receive blood from four many tributaries. To receive blood from the great cardiac vein, middle cardiac vein, small cardiac vein, posterior cardiac vein. So the great cardiac vein is this one here on the left. And then you also have the middle cardiac vein. The middle cardiac vein is also known as the posterior interventricular vein. So this one that you can see here, okay, that's the posterior interventricular vein. And then actually the posterior interventricular vein and the middle cardiac vein are supposed to be different. You can see this is the posterior cardiac vein. Now you have got the middle cardiac vein, which is this one. Passing through, this is the posterior interventricular sulcus, dividing the left ventricle from the right ventricle posteriorly. So the middle cardiac vein, we can also call it the posterior interventricular vein. Okay, that is correct. Okay. You also have the posterior cardiac vein, different from the posterior interventricular vein. And then the small cardiac vein, which comes from the right hand side here. Okay, so those are the ones who are going to drain into the coronary sinus. You have some other veins which do not drain in the coronary sinus, but instead will drain directly into the right atrium. The anterior veins of the right ventricle, or anterior cardiac veins, these ones that you can see here, these ones will drain directly into the right atrium. You also have the venae cordis minime, or veins of Thebesius. This one also drain dirt into the heart without going to the coronary sinus. So just these two. There's also one that I've not talked about. It's known as the oblique vein of Marshall, or the oblique vein of the left atrium. There's a vein that will be going here from the coronary sinus, just coming from the left atrium going to the coronary sinus, known as the oblique vein of the left atrium. Let's now talk about blood flow. Blood flow is represented by Q. So you can see the pattern of blood flow can either be laminar or turbulent. The meaning is that it can either move in a straight line or it can move in a confused manner. Now the way the blood moves is going to be denoted, actually whether it's going to be laminar or turbulent can be denoted by Reynolds number. Reynolds number is given by diameter times velocity times density divided by viscosity. Viscosity is just that when blood is flowing, that resistance that it experiences, that is known as viscosity. Okay, are we going together so far? Okay. So the Reynolds number can also be given. This is the equation that you can see here. Okay. Density times velocity times the diameter of the blood vessel divided by viscosity. So if the blood has a laminar flow, it means that it is moving in a straight line. That is a laminar flow. and that will mean that the Reynolds number is small, less than 2000. That is the number. Now remember, if a Reynolds number is small, it means that one of the quantities on top of this equation is actually small. So that tells us that when we increase any quantity on top, the Reynolds number is going to increase, and that becomes a turbulent flow. That is why when blood is moving very fast, if it is moving very fast, it is not going to move in a straight line, it's going to be turbulent. Okay, and in that case, you are also going to be hearing some noise in the blood as blood is moving, audible vibrations. So Reynolds number is going to be greater than 3000. Okay, so what are the factors that increase Reynolds number? Remember, if you increase Reynolds number, it means that you are promoting turbulent flow. Blood will not be able to move normally, to be just moving anyhow like that. If you increase the diameter of the tube, remember diameter is on top when you're calculating Reynolds number. It means that you're also going to increase tubular flow. Increasing velocity, velocity is also a quantity on top. Decreasing blood viscosity, because viscosity is in the diameter. So if you decrease the diameter, it means you are increasing the entire fraction. Okay, for example, someone who has got anemia, the blood decreases in viscosity, meaning that the blood will not be able to hold that much. Okay, it loses that capacity to be able to hold. For example, think of the way oil and water is. Water has got a small viscosity, that's why it can flow very fast. But oil has got a high viscosity, that is why when you let it slide, to not be able to move that very fast, there is a resistance. And also for narrow orifice also is going to be able to affect the Reynolds number by increasing it. And why is it like that? Because the narrow orifice, for example, in severe stenosis, is going to increase. Like, there's, think of it, a hose pipe that is having a small lumen and the one with a big lumen. A small lumen, there's going to be high speed, so you're increasing actually speed. Okay. Another thing that you need to understand is about the tension in the walls of the blood vessels. According to the Laplace relationship, tension is going to be pressure multiplied by radius divided by the wall thickness. So the aorta is going to have the greatest wall tension. There's going to be a lot of tension as blood is getting to move. You also have something known as vessel compliance. Compliance is just meaning how easily you can stretch something. To stretch is just to pull like something. Okay. So something that can be easily stretched, it's very compliant, while those which cannot be easily stretched are non-compliant, or they are stiff, meaning you can't stretch them, they are not compliant. Systemic veins are more compliant than systemic arteries, meaning that for veins you can more stretch them, arteries more resist that stretching. So compliance, also known as capacitance of a blood vessel, would describe the volume of blood the vessel can hold at a given pressure. So veins have the highest compliance, as we've already said. And compliance is going to be related to distensibility, how much you can distance a blood vessels. And that is going to be given by compliance is equal to volume over pressure. Okay, volume volume is just meaning how much a blood vessel can fill divided by the pressure. What are some factors that affect systolic pressure? The pressure in the heart, when the heart is pumping blood. Remember, systole is contracting. So increase in stroke volume. Stroke volume is just the amount of blood that is available in the heart. So the amount of blood that is available in the heart will determine how much the heart will be able to contract to push it. And also decrease in heart rate will affect stroke volume. Decrease in vessel compliance also affects, systolic pressure, not stroke volume. Okay. Factors that affect diastolic pressure. The pressure in the heart when it is relaxed. There are a lot including heart rate, stroke volume, compliance, and those other ones. You also have pulse pressure. Now pulse pressure is just a difference between end diastolic volume and end systolic volume. Okay, let's talk about the Starling's law of the capillaries. Starling's law just states that when fluid is flowing, the amount of blood that is going to go to the tissue is going to be determined by the difference in the forces trying to push the blood out of the blood vessels minus the pressure trying to keep the blood inside the blood vessels. And that blood that goes out of the blood vessels becomes the interstitial fluid. Force that tries to push things out of the blood vessels is known as colloidal pressure or oncotic pressure. And then that one which tries to keep things inside the blood vessels is known as the osmotic pressure. So to find the rate of flow of substance out of the blood vessels, we are going to get the amount of force trying to push things out. Okay, so we want to find out the rate at which liquid will be able to flow or fluid will be able to flow out of the heart. So it's going to be given by the pressure trying to push things out. So that is going to be the colloidal pressure. Remember, colloidal pressure is trying to remove things. Okay, here. And then you are going to also remove pi. Now here we have got the end which is venous and the end that is the arterial. The red one, the red end that you can see is arterial. So in other words, just get if you are talking about both ends, the venous end and the arterial end, just get the force which is trying to push things out of the arterioles and the veins, and then remove what is trying to push things inside the arterioles and the veins. That will give you a difference of what has moved out. So this is the same thing which I'm just from saying. How about flow? Flow of blood is going to be determined by the consumption of oxygen divided by the arterial minus venous oxygen content. Oxygen consumption is just that amount of oxygen that is delivered to tissue. So we're going to first find out how much oxygen has gone to the tissue. Let's say you had 20 liters going to the tissue and then only 5 liters is coming out. So meaning that the difference is what has been used. Okay, and then cardiac output. Cardiac output, according to Fick's principle, is just oxygen going into an organ minus oxygen leaving an organ, and that must be equal to the oxygen that has been used up by the organ. So meaning that cardiac output is oxygen consumption divided by oxygen content in arterial blood minus oxygen content in venous blood. And if you look at the cardiac output to different organs, when the heart pumps blood, 100% of blood is going to be able to move. It will go to the lungs. So the lungs receive 100% of the cardiac output. And then it will be able to go now also to the aorta. The aorta also receives 100%. And then now it will be distributed. You can see 15% will go to the brain, 5% to the arteries which supply the heart, the coronary arteries. 25% is going to go to the kidney, And you can see the kidney, same with the GIT and the skeletal muscles. These are the ones which receive the highest amount of cardiac output. The skin will receive 5%. Velocity at which blood is flowing can be given by the flow rate divided by the cross-sectional area. So because cross-sectional area is in the denominator, it means that it is inversely related to the velocity at which blood is moving. For example, you can see if you have got the same area, the same cross section, I mean the cross section areas are differing, the same flow rate, blood is moving at the same rate, but then you differentiate areas, okay? Same flow rates, but you just are having different areas. What would be the velocity? You can see the more you increase the area, the lesser the velocity you get. So the velocity of flow is going to be lowest in vessels with the largest cross-sectional area, because area is actually inversely proportional to velocity, and the highest in the vessels with the smallest total cross-sectional area. So the aorta has got a small total surface area in comparison to all the capillaries in the body. So since the aorta has got a small surface area, it's going to have a very high speed, while the capillaries are going to have a very low speed because they have got a big surface area. You can look at a simple problem here. A man with a cardiac output of 5.5 liter per minute. The diameter of his aorta is estimated to be 20 millimeters, and the total cross-sectional area of his systemic capillary is estimated to be 2,500 cubic centimeters. What is the velocity of the blood flow in the aorta related to the velocity of the blood flow in the capillaries? The first thing is we need to find the area of the aorta mentioned. Area is given by pi r squared because these ones are circular. Pi is about 3.14. How about the radius? If we check in this question, the iota has got a diameter of 20. 20 divided by 2 give you the radius, which is 10. And then 10 squared, you multiply that to give you 3.14 cubic centimeters. Now, capacitance, which is also known as compliance. Remember the question is saying, what is the velocity? So the first, okay, we want to find first the velocity. Okay, the velocity in the capillaries. Velocity in the capillary is going to be flow rate over area. The flow rate is the same that you've been given, 5.5 liter per minute, but the area, the cross-sectional area of the capillaries, we've been given already the area is 2,500. So that is going to give us 2.2. And then the velocity in the aorta is also flow rate over area. The flow rate is the same, but the cross-sectional area we found 3.14. So that gives us 1,752 cubic centimeters per minute. Not cubic centimeter, but just centimeters per minute. So what is the velocity of blood flow in the aorta relative to the velocity of the blood? So now just compare these two. How many times relative to the velocity of the blood in the capillaries, how many times is this number going into the aorta? So that will give you the comparison, how many times that will be. Okay. Relationship between blood flow, pressure, and resistance. Blood flow is actually going to be equal to the change of pressure over resistance. This is supposed to just be a Q, not QP. So flow is change in pressure over resistance. Resistance to blood flow is going to be best explained by Postle's equation. Postle's equation tells us that resistance is H times viscosity times the length of the tube divided by pi r to the power 4. Meaning that if you reduce the radius, the rate of the resistance of that artery or arterial or vein or whatsoever is going to increase by a very big factor. Just if we half, okay, if we half the radius, 1 over 2 to the power 4 is going to give us 16. So the resistance is going to increase by a factor of 16. Total peripheral resistance is the resistance of the entire systemic vasculature and is also called the total peripheral resistance. Okay, TPR also called like that, or is also known as the systemic vascular resistance. The resistance as blood is moving to the system, to the other body parts. And then you also have resistance in a single organ as blood is going to that organ. So look at this question. Renal blood flow is measured by placing a flow meter on a woman's left renal artery. Simultaneously, pressure probe are inserted in her left renal artery and left renal vein to measure pressure. Renal blood flow measured by the flow meter is 500 mils per minute. The pressure probe measures renal arterial pressure as 100 millimeters of mercury and renal venous pressure as 10 millimeters of mercury. What is the vascular resistance of the left kidney in this woman? Now we know that resistance is given by the pressure divided by the flow rate, which is also given by, so pressure, just talking about the change. You talk about the pressure in the arteries because the arteries are taking blood, right? And then the veins are taking back blood. So how much blood has been taken and how much blood is coming back will tell us how much blood remained in that organ. And if we divide that now by the renal blood flow, that will give us resistance. So the pressure in the renal artery, we've been told that it's 100, in the vein is 10, divided by the renal plasma flow, how much fluid is going to the kidney, that's renal plasma flow, that is 500. How do you find that 500? You know that 25% of the renal of the cardiac output goes to the kidney. So if you say 25% and the total cardiac output is like, is it a 5,000 mils or 5 liters? You can try to do that calculation. But already in this question, we have been given how much is the renal plasma flow. So you don't even need to worry about that. So that will give you 0.18 millimeters of mercury per mil per minute. You also have this one. Said the man suffers a stroke caused by partial occlusion of his left internal carotid. An evaluation using a magnetic resonance imaging shows a 75% reduction in its radius. Assuming that blood flow through the left internal carotid artery is 400 mils per minute, what is the blood flow through the artery after the occlusion? This is after the occlusion. So already, if we can calculate first the resistance, resistance is given by the Postle's equation, but we're only interested in the radius because that's the only thing that has been given to us. And we know that according to the radius, it is 1 over radius to the power 4. But here in this question, being told that blood flow has been reduced by 75%. If something has been reduced by 75%, 75% is the same as 3 quarters. It means that it has been reduced to 1 quarter because 3 quarters is no longer working. So what is just remaining to work is 1 quarter. So resistance is going to be 1 over 1 quarter to the power 4, and that is going to give us like a 256. Now we know that flow, because the question is asking us to say what is the blood flow, and we know that flow rate is change in pressure over resistance. So the change in pressure has not been named, So just put a 1 there over 256, which is the resistance. So that is going to give us about 0.39% of the original one. If, but if we punch, we're going to get 0.039. So this means that after an occlusion, blood is flowing at a rate of 0.039 times that of the original. And after this occlusion, have we been told anything in this question? Okay. Look at this. We've been told that assuming the blood flow through the left internal common cavity is 400 before the occlusion. So before the occlusion is 400, meaning that after the blood vessel has been occluded, what will be the flow? The flow so is going to be 0.39% of 400, and that will be 1.56. Arterial pressure in systemic circulation. What will be some pressures as blood is moving in the system? So when the heart contracts, you have got first diastolic pressure. Diastolic pressure is the pressure when the heart has just, this is the lowest kind of pressure, which is measured when the heart has relaxed. So what is the pressure that the blood is moving at when the heart has relaxed? It is not pumping. That is going to be like 80 millimeters of mercury. Systolic pressure is the highest arterial pressure, and it is a pressure when the heart has just contracted and is max at 120 millimeters normally. So if you find the difference between these two, that will give you the pulse pressure. Pulse pressure is the difference between systolic pressure and diastolic pressure. So if every other factor is held constant, you find that the pulse pressure is going to be equal to the stroke volume. Stroke volume is just the amount of blood that is remaining in the heart after the heart pumps blood, and that is the pulse pressure, which is given by systolic blood pressure minus diastolic blood pressure. Okay, I gave an example here and it gave us 40 millimeters of mercury. You also have the mean arterial pressure. Now, the mean arterial pressure is the average pressure in the cardiac cycle. Mean does not mean that you just add and then you divide. Mean in this case, mean arterial pressure is 2 multiplied by diastolic blood pressure plus systolic blood pressure over 3. We know that diastolic blood pressure is like 80, systolic is 120 over 3, so that will give us around 93.3. Other terms we need to understand is stroke volume, ejection fraction, and cardiac output. Stroke volume is the blood that is ejected by the ventricle on each beat. How much blood is moving out of the ventricle in each beat. Okay. And then ejection fraction is the fraction of the end diastolic volume ejected in each of a stroke volume. In other words, when blood moves out of the heart, now I want to calculate as a percentage that blood that goes out of the heart. Okay. And so that will tell you how efficient the ventricles are in pumping blood. Cardiac output is the total volume ejected by the ventricles per unit time. So stroke volume is just a volume ejected on one heartbeat, and it's mostly 70 mL per heartbeat. That's how much blood is ejected. Ejection fraction is given by the stroke volume over end diastolic volume. So what we're talking about is the volume that has been ejected divided by the volume that was in the heart when the heart was relaxed. So that will give you the percentage of blood that has moved out of the heart. And then cardiac output is just a stroke volume times heart rate. Cardiac output is also given by oxygen consumption divided by oxygen in the pulmonary vein minus oxygen in the pulmonary artery. In the vein minus in the artery. This one, cardiac output is stroke volume times heart rate. And the normal cardiac output, how much blood is going to be pumped out of the heart in each minute, is going to be 5 liters. Of these 5 liters, remember 25% of the 5 liters is going to the kidneys, 25% also to the muscles and such. Okay. So we said cardiac output is also oxygen consumption over oxygen in the vein minus oxygen in the artery. And this is pulmonary vein, meaning that oxygen in the vein coming from the lungs to the heart, and then oxygen now in the blood being taken back to the heart. So blood was coming from not to the heart by the lungs. Blood was coming from the lungs. We knew the oxygen content. Now blood is going to the lungs back. We know the oxygen content. So if we subtract these two guys, how much oxygen we find is how much oxygen was used up by the body. Okay. For example, a man has an end diastolic volume. So at the end of a diastole or a relaxation, the ventricles have got 140 mils of blood, and then an end systolic volume of 70 mils and a heart rate of 75 beats per minute. What is the stroke volume, is cardiac output, and is ejection fraction? So starting with stroke volume is given by end diastolic volume minus end systolic volume. End diastolic volume after the blood received when the heart relaxes is 140. The now that remains in the heart after the heart contracts, that is 70. So stroke volume will tell you of the blood that has gone out of the heart, and that is 70 mils. Cardiac output is stroke volume times heart rate. Stroke volume, we've been told, that is 70. Now stroke volume is always the amount of blood that is pumped in each beat, so mils per beat. Heart rate is the beats per minute. Normally it's between 60 and 100. In this case, we've been given 75 beats per minute. So that is going to give us 5,250 mils per minute being pumped, which is also 5.2 mils per minute. So that's liters per minute, I mean. So that's how much blood is being pumped. Ejection fractions will be given by the stroke volume, how much blood has been pumped out of the heart, divided by how much blood was in the heart when the heart was relaxed. So that is 70 over 140, and that will be 0.5. A man has a resting oxygen consumption of 250 mils of oxygen per minute. A femoral arterial oxygen content of 0.2 mils of oxygen per mil of blood, and a pulmonary arterial oxygen content of 0.15 mils of oxygen per mils of blood. What is his cardiac output? Now know that cardiac output is oxygen consumption over oxygen in the pulmonary vein minus oxygen in the pulmonary artery. In the pulmonary vein, look at this. We've been given 0.20. That is in the femoral artery. So you can also say oxygen in the artery minus oxygen in the vein. Okay. Basically, what is going minus what is coming back. So that is going to give us about 5 liters per minute, which is not too different from the other one which you found here. Yes, it says. Yeah, it's a one. Okay, so we have got also the Frank-Starling's relationship. This Frank-Starling's law or relationship of the heart is based on an experiment that volume of blood that moves out of the ventricles will depend on the volume of blood which is present in the ventricles at the end of a relaxation. So how much you are going to push away will depend with how much is available. So the volume present at the end of a diastole also depends on the volume that has been taken back to the heart, and that is known as venous return. Cardiac output, how much blood moves out of the heart, therefore is going to be equal to the venous return, how much blood goes back to the heart. So that means that stroke volume, which is the amount going out of the heart, cardiac output, that is also like amount of blood going out of the heart. These are also going to be related to the end diastolic volume, the amount of blood in the heart when the heart is relaxed, and that correlates to the venous return. So if you look at the ventricular pressure to volume loops, look at this. Here we're talking about the the pressure in the left ventricle, and then the volume in the left ventricle. So what happens that there's going to be a period when the ventricles are going to be getting blood. You can see we are getting blood. Blood was 50, now it's 120. We are getting blood, but the pressure in the ventricles is not increasing. You are just filling the ventricles. And then what happens is that the mitral valve closes, meaning that blood can no longer enter the ventricles anymore. Now, the mitral valve has closed, but also the aortic valve is also closed. That valve that should allow blood to move out of the ventricles to the aorta is also closed. So meaning that the blood is now just there. It has got nowhere to go. So what will happen is that pressure will start building up in the ventricles. Okay, so pressure is building up, but the volume is not changing because all the valves has been closed. Now what happens that when the aortic valve opens, blood can be pushed out of the heart, so the volume that remains in the heart drops again. And then when this valve closes, the pump or the aortic valve, the pressure will also start now to drop. Okay, when the pressure starts to drop, the mitral valve now opens again to allow blood to come from the atrium to the ventricle, like that. So this is also the same. So we have got diastolic feeding. We are feeding the ventricles while it is relaxed. And then we have got isovolumetric contraction. The ventricles are contracting, but volume is not changing. And then we have got ventricular ejection. We are removing blood. And then we have got the isovolumetric relaxation. Okay, the ventricles are relaxing, but volume is not increasing. And then back to diastolic feeding. And then another thing that we need to understand is about the electrical activity of the heart. Heart beats in the absence of any nervous. The heart can beat even if you don't have any nervous connection. Okay, that is because the heart has got its own pacemakers, which are within itself. So the contraction of the heart is going to be initiated when there is a spread of an action potential. The conduction system of the heart is going to consist of the SA node, the internodal arterial pathway, the AV node, and the end atrial ventricular bundle of his, which can either go to the left bundle branch or the right bundle branch, and then the Purkinje fibers. So you can see the depolarization is going to start on the SA node. From the SA node, depolarization is going to spread to the atrioventricular node, and then it will go to the atrioventricular bundle, the bundle of His. The bundle of His is going to split into the left bundle branch and the right bundle branch. And then from these, you are going to go to the Purkinje fiber. Now, these ones you can see, this conduction system, they are not nerves, they are actually muscles. Okay, they are muscular in nature, not nervous in nature. That's why we are saying the conducting system consists of specialized myocardial cells. These are not nervous like that. So the normal pulse that is going to be generated by the conduction system and also the velocity. The SA node, if it's the one generating a heartbeat, to generate a heartbeat of 60 to 100 beats per minute, which is the normal one, the AV node generates 40 to 60 beats per minute, which is a bit slow. Package fibers, if they're the ones that are generating an action potential, it will be 15 to 30 beats per minute, which is like bradycardia, is slow. But then the velocity of impulse is going to be very much fast if the impulse is generated in the Purkinje fibers. Actually, the fastest velocity of impulse results when the impulse is generated in the Purkinje fiber, and then the slowest is the impulse generated in the SA node and AV node are very small. They are very slow, as you can see. So we have got fast response action potential. The fast response action potential occurs in the Purkinje fibers, ventricular, also in the ventricular muscles, and also normal atria. The slow ones, we said SA node and the AV node. Now, starting with the fast action potential being generated like in the Purkinje fibers, in the atrial, and also in the ventricular muscles. Myocardial cells have got a stable resting membrane potential of around negative 90 millivolts. The action potential duration is going to be longer than that of the neuron, so the action potential endure up to 250 milliseconds, and is going to have 5 phases. We have got phase 0, which is a rapid depolarization. This depolarization is caused by sodium influx. The sodium is entering the cell via sodium channels, voltage sodium channels. And then you have got phase 1, which is early rapid repolarization. So when the sodium channels become inactive, the cell begins to repolarize because potassium channels will become active and they'll start going in. You also have the plateau phase, which is phase 2, and the plateau phase is caused by calcium influx. Okay, remember you have got a rapid depolarization, which is this one because of sodium influx. So positive charge was entering the cell. Now, when positive charge started leaving the cell, this graph starts dropping because positive charge is leaving the cell. But as positive charge is leaving the cell, calcium starts to enter. So this graph ends up forming a plateau here because of calcium influx. And actually, calcium is entering the cell using the L-type calcium channels. And then now you have got the calcium channels closing, okay, and the potassium channels remaining open. So there is now a drop. This is now a repolarization, and then you go to the resting, which is the phase 4, and that is caused by delayed potassium channels. For a cardiac muscle to contract, the first thing is there should be initiation. So there should be an action potential via either the pacemakers, or let's say whatsoever that is going to cause that action potential, which should go to the conducting fibers. And we've talked about the conducting fibers, the SA node and these others. When that happens, you are now going to have the excitation contraction coupling. You are going to start with calcium induced, calcium released. Okay, so the action potential is going to spread along the sarcomere, and then the T tubules, they do contain voltage gated L-type channels, because these L-type channels, they can sense voltage coming via an action potential. They are going to open when depolarization reaches where they are. When they open, then calcium is going to be allowed to enter the cell, and when it enters the cell, it is going to open the rhodin receptors. Okay, rhodin receptors are found on the sarcoplasmic reticulum. When that happens, so calcium had entered, so calcium in the sarcoplasmic reticulum now is going to be released. When calcium is released from the sarcoplasmic reticulum that causes a spark. So there's an increase in calcium, and that is going to cause multiple sparks, which are going to cause contraction. We know whatsoever that happens, that the calcium binds to troponin and everything else like that. So for relaxation to happen, you need to take back the calcium to the sarcoplasmic reticulum. Apart from taking calcium to the sarcoplasmic reticulum, calcium can also be removed out of the cell via a sodium calcium exchanger. You can see calcium is moving out, sodium is moving in. Actually, 3 sodium in, 1 calcium out. So this is important to take note of. What causes relaxation in a cardiac muscle is, one, the entry of calcium back into the sarcoplasmic reticulum, and also the removal of calcium from the intracellular fluid via the sodium calcium exchanger. We also had the slow responses. Now for the slow responses, that's the SA node and the AV node. They are characterized by unstable resting membrane potential, okay, also known as pacemaker potential of about -55 to -60, which is like phase 4 of depolarization. These pacemaker cells have a lesser negative resting membrane potential because they are leaky to sodium and potassium. So their membrane potential is a bit low. Why is it like that? Because these are leaky. They actually are just normal conditions. They allow sodium and potassium to be passing through them. Okay. So when sodium and potassium is entering the cell, it is already lowering the the action potential, drawing it closer to the to the threshold, right? Like that. So for these ones, which are the slow response action potentials, they only have 3 phases: phase 0, phase 3, and phase 4. They don't have all of them. Phase 0, remember, is an upstroke of action potential. Phase 3 is a repolarization, and this was happening already afterward. This repolarization is happening after the plateau. And then I've got phase 4, which is now the resting phase. Okay, resting phase. The ionic basis of action potential. Now for this one, for the slow response action potentials, phase 4, here we're going to be having opening of voltage gated sodium channels called Fanny channels or I channels, and the closure of voltage gated potassium channels. Remember, in phase 4, what happens there is actually the there is a repolarization which is happening. So there is opening of voltage gated sodium channels and cold Fanny channels, closure of potassium channels. Now there's a repolarization when you're talking about the fast action potential uh, pacemakers, not the slow ones. For the slow ones, you can see when you are opening sodium channels, it means that you are allowing depolarization to enter. So this is going to be a point, phase 4 will be a point of depolarization for the slow action potential pacemakers, different from phase 4 of the fast ones. There's also going to be opening of voltage gated transit type calcium channels. Now these are the T type calcium channels, different from the L type, which are voltage gated, which we saw earlier. Phase 0 now is going to be the rising phase or depolarization, and this is going to be now opening of lasting voltage gated calcium channels, which are also known as the L type calcium channels. Phase 3 will be the falling phase or repolarization, which is the closure of the L type calcium channels. So this is what you can see. You start with phase 4. So you can see phase 4, there is sodium channels opening, potassium channels closing. So depolarization is happening. When you reach the threshold, then there's going to be now the opening of T-type calcium channels and the closure or deactivation of the sodium Fanny channels or I channels. So there's going to be that now fast depolarization. And then now in phase 3, there's going to be a closure of the L-type calcium channels and an opening of the potassium channel. Now remember, potassium starts flowing back into the cell, out of the cell, and that causes a repolarization, and the process continues like that. Okay. What will be the effect of sympathetics on the pacemaker activity of the cell? Now, sympathetics, for example, norepinephrine is one of those important hormones produced by the sympathetic nervous system. Norepinephrine is going to be able to increase the Fanny channel activity. So because of that, they are going to be able to bind the norepinephrine binds to beta 1 adrenergic receptors. Please take note, sympathetic nervous system will work via the beta adrenergic receptors, and these ones will activate cyclic adenosine monophosphate. Cyclic adenosine monophosphate to increase the number of the Fanny channels, okay, the Fanny sodium channels. And when these guys have been increased, they are also going to increase the opening of the L-type calcium channels. And when these ones can open more, that is going to cause more rapid pacemaker potential and a faster rate. That is why you can see with sympathetic innervation, you can see the rate is much faster. It is happening very quickly. Look, it started earlier, forming a complete wave even before this normal one can even form a wave. Okay. So sympathetic activity can be summarized. We have got what is called, there's going to be increased chronotropic effect. Chronotropic effect just means that there's going to be increased heart rate if there is sympathetic. Think of you are running. And then there's also going to be increased the dromotropic effect, meaning that is an increase in the conduction of action potential. That's dromotropic. There's also going to be increased effect of what is known as ionotropic. Ionotropic just means there's going to be increased the contractility. So this is what happens when there is sympathetics. Parasympathetics will be the opposite. It's going to decrease chronotropic, decrease dromotropic, decrease contractility. And the most important hormone or substance used in the parasympathetic nervous system is acetylcholine. Now, acetylcholine does not work via the beta 1 receptors. Instead, it works via the muscarinic receptors. Take note of this. And this one increases, acetylcholine will increase potassium permeability. Because it's increasing potassium permeability, that is why it is reducing the normal heart rate, okay, or membrane potential. You can see it is taking a much longer time for it to rise like that. So there is been a slowed membrane potential. So this is how the sequence of the cardiac excitation is going to be. First, the atrium is going to be excited, and it will begin with the SA node. The SA node will send out those impulses, okay, and so you can see we are seeing a P wave almost starting to make. And then when the action potential spreads all the way to all the atria, there is a complete depolarization of the atria. So that's why you can see a P wave. But the atria would depolarize and repolarize. So that's why you can also see it has also gone down like that. Okay. And then the action potential spread to the interventriculus, to the septum, and that is going to cause this kind of downward deflection that you can see. Then you start going a bit up like that, and then after that depolarization, the entire ventricles will be depolarized, and that will be represented by the by the QRS complex. And then what will happen is that they will now repolarize, and that will be represented by the T wave that you can see, which is repolarization of the ventricles. We have something known as excitability and refractory period. Excitability is just the capacity of a myocardial cell to generate action potential when there is a depolarizing current. Now, to be even more specific, when you're talking about excitability, you're talking about the amount of inward current that is going to be required to bring the myocardial cell to the threshold. Remember, the threshold is what is needed for this cell to be able to do what? To be able to actually fire like that, isn't it? So during those phases of the action potential, when membrane potential has depolarized, so after depolarization happens, what we expect is repolarization to happen. So the sodium channels will begin to close. So when the sodium channels close, it means that even if you start pricking me again, okay, when the sodium channels are closed, inward depolarization, you can't have another depolarization through them. Okay, and so there's going to be no upstroke. There's not going to be any action potential again, because sodium channels have been closed. They can't allow sodium to pass through them. And that period where a depolarization cannot happen is known as a refractory period, because the sodium channels have been closed. So you have got a refractory period and the absolute refractory period. Now, the absolute refractory period is this period that you can see from here all the way to somewhere here. This is telling us a time when the sodium channels have been closed. It's only the potassium channels which are open. So whatsoever that you do, sodium channels cannot open. This is absolute. The sodium channels cannot open, and so you can't have another action potential. But for the relative refractory period, this is the distance that you can see here. This is the period when some sodium channels have started opening. Okay, some sodium channels have started opening. So you can have another action potential after you stimulate your heart. But then for you to be able to have another action potential, you need to have a stronger stimuli, much stronger than the original one, because you only have few sodium channels which are open. So you need a stronger stimuli that to allow the influx of sodium to be able to cause another action potential. Does this make sense? Is this okay? Okay. And then now the electrical activity of the heart, the ECGs. So on the ECG, we are going to have a P wave. A P wave is just the duration when there is depolarization of the ventricles. This is depolarization of the ventricles. Now you can see between the P wave and the Q wave, you have got an isoelectric point. Every time you see a straight line on an ECG, that is called isoelectric point. It means that there is no net action potential there. Okay. So we have got a PR segment. Every time you hear segment, segment is always is always an isoelectric point. And then you have got now the QRS complex, which is representing the depolarization of the ventricles. Now imagine, why did we move from the depolarization of the atria to the depolarization of the ventricles? How about the repolarization of the atria? The repolarization of the atria is actually covered in the depolarization of the ventricles. That's why you don't see another way for repolarization of the atria. That's the one which you can see a bit down here. And then after the ventricles depolarize, they'll still repolarize. That is the T wave. Okay. You also have another isoelectric point here. So the P wave is normally completed after zero point 0.1 seconds. You can give a range as 0.08 to 0.12 seconds. And then the PRI interval. Now, an interval is a combination of different things. In this case, PRI interval will cover the P wave going all the way to the beginning of the QRS complex. That's a PRI interval. And this will be the PRI interval is the time from the initial depolarization of the atria to the initial depolarization of the ventricle. If we say initial depolarization of the atria, we're talking about all the way from this beginning of the P wave to just where the ventricles want to start depolarizing. That's the beginning of the QRS complex. And that one lasts for about 160 milliseconds. Also, like that is 0.16 seconds with the same range as a P wave, which is 0.12 to 0.2 seconds. The QRS complex is having the same range as the P wave. The PRI interval, the range is a bit higher than the P wave actually. Consider 0.1 to 0.2. While the QRS complex is 0.08 to 0.12, that's the same as the P wave, that's the period it takes. And the QRS complex shows the depolarization of the ventricles. You also have a T wave, which is a repolarization of the ventricle, and it's about 0.25 to 0.35, very fast. QT interval, every time you hear of an interval, now this is the QT interval, it will include the entire QRS complex and the entire T wave. That's a QT interval. And this one is a segment represents the first ventricular depolarization to the last ventricular repolarization. So depolarization and repolarization of the ventricles is represented by the QT interval. Okay. You also have the ST segment there. Now ST segment is just that isoelectric point where you are not having anything. So the QT interval is about 0.35 seconds. It's also very fast. If you look at an ECG, you have got a big box and small boxes. On the horizontal, a big box will represent 0.2 seconds, 0.2 seconds. So if you want to find out the time for each small box, divide 0.2 by 5 because there are 5 each one of them. And then going up, it will represent the voltage. So 5 boxes will represent 5 millivolts, meaning that one of these boxes inside will represent 1 millivolt. Heart rate is just the number of cycles or the number of beats the heart has per second. And you can calculate the heart rate using different ways. You have got the rule of 300, where you're just going to be able to calculate or count the number of big boxes between neighboring QRS complex and then divide by 300. You have got 1, 2, 3, 4, 5, 6. Divide by 300. That will give you like a 50 beats per minute. This one is only good for regular rhythms, not those which are irregular. And then you also have the rule of 10 seconds. This one, because most ECGs or they called 10 seconds. So what happens that you simply count the number of beats present on the ECG and multiply by 6. So you count all of these 1, 2, 3, 4, these beats that you can see. For this one here, if you count them, there'll be 33. You multiply by 6. So that will give you the heartbeat, which is 198 in this case. Okay, I think that would be enough for us to look at on cardiovascular system.